So what I am talking about, the acute poisoning of the tricyclic antidepressants. When there are acute poisoning, there will be depressed respiration, there are delirium, anticholinergic symptoms, there are muscle spasm, convulsion, coma, and ultimately death can happen if the treatment is not initiated within a few hours. Mainly, firstly, support have to be given according to the gastric lavage, respiratory assistance, fluid infusion, maintenance of the blood pressure and body temperature. And remember, the main drug that is used for the tricyclic antidepressant poisoning is the bicarbonate. So IV sodium bicarbonate is usually given mainly to change the acidosis, and it also acts to decrease the side effects from the tricyclic antidepressant poisoning. And after the patient is supported, then for diazepam can be given for convulsion or delirium, or other drugs can be given like to treat the cardiac arrhythmia, propranolol or lidocaine can be given. So remember, for tricyclic antidepressant, the first line of the drug is the IV sodium bicarbonate. Okay. And there may be interactions with the other drugs also. They are strongly bound to plasma protein. That's why there are, if some other drugs that can replace these drugs from their plasma protein binding site, that can lead to toxicity of the drug also. They are metabolized by the liver microsomal enzymes. Again, other drugs that can inhibit or induce these liver microsomal enzymes, there may be problems of the metabolism of these drugs. So, if they are given with this MAO inhibitor already I am talking, or if they are given with some tyramine containing food or this tricyclic antidepressant, there may be sudden rise of the blood pressure. This is known as the hypertensive crisis. So, hypertensive crisis can happen. So, you can see the tricyclic antidepressant drug. So, mutual enhancement of their effects can happen when we are using some other monoamine oxidase inhibitor. You can see there is enhancement of their effect. So, there may be hypertension, hypertensive crisis, hyperpyrexia, very high temperature of the body, convulsion and coma can happen. If we are using some other directly acting adrenergic drugs with this tricyclic antidepressant, they also potentiate these effects, and there may be different types of the adverse effects. On the other hand, if the ethanol or other CNS depressants are used, that also leads to toxic sedation. So, sedation will be toxic. Again, the patient can go to the coma. And again, if we are using high dose of the indirectly acting adrenergic drugs, that also leads to toxicity. So, the other drugs have to be given cautiously when we are using the tricyclic antidepressant drugs. So, amoxapine is another drug. This is basically some modification with the tricyclic antidepressant. That's why this is a tetracyclic compound, and it also blocks the dopamine receptors in addition to their norepinephrine receptor blockade. So, there are some additional action of the dopamine blockade. Otherwise, more or less similar mixed antidepressant and neuroleptic properties are there. Risks of extrapyramidal side effect is also there. When we read about the antipsychotic drug, we will see that the extrapyramidal side effect is most common side effect of the typical antipsychotic drug. Since they have some neuroleptic property like antipsychotic property, they have also an extrapyramidal side effects. Details is not required, just remember the name and about their dopamine blocking action. So, contraindication, these tricyclic antidepressants should not be used in patients with glaucoma and with enlarged prostate, because there may be some urinary retention. More urinary retention, there may be anuria, urine cannot come at all. This can happen due to their atropine-like action. These are contraindicated in manic depressive illness, that is bipolar illness. When there is bipolar illness, we are treating the depression, the patient ultimately leads to manic episodes. So, that is the problem. Here, for the bipolar disorder, we have to use the lithium salts. We will discuss in the next class. Next, the monoamine oxidase inhibitor. We have started with the monoamine oxidase inhibitor. These are the monoamine oxidase inhibitor: phenelgine, tranylcypromine, isocarboxazide, moclobemide and pargylene. Onset of antidepressant action similar, minimum 2 to 4 weeks is there. This is found in nearly all tissues located intracellularly associated with mitochondria. Mitochondria moddhe thake. Present in nerve terminals that release norepinephrine, dopamine or 5-hydroxytryptamine, located on outer surface of the mitochondrial membrane. So, cell je mitochondria thake ta outer surface e in monoamine oxidase gulo thake. In neurons, this monoamine oxidase oxidatively deaminates and inactivates any excess norepinephrine, serotonin and dopamine. মানে যখন যে monoamines গুলো আসছে synaptic cleft এ, some part of it is metabolized by this monoamine oxidase. Okay, this monoamine oxidase oxidatively deaminates and inactivates this, and some part of it is reuptake by means of the back to the presynaptic neuron. So here we are blocking the metabolism of these monoamines. So monoamine is not involved in the inactivation of the release transmitter. So already release transmitter inactivation সাধারণত হয় না, তার আগেই রিলিজের আগেই ইন্ট্রাভেসিক্যালি আমরা সেটার কিছুটা মেটাবলিজম করে দিতে পারবো যদি আমরা ইনহিবিট করি monoamine oxidase কে by means of the monoamine oxidase inhibitor. So you can see this monoamine oxidase inactivates the monoamines, norepinephrine, serotonin and dopamine. These are the monoamines that leak from a synaptic vesicles. So these are the synaptic vesicles that mainly contain the monoamines that comes to the synaptic cleft. Before coming to the synaptic cleft, some part of it is metabolized. So effect of the MAO inhibitor, when we are inhibiting this, they prevent the inactivation of the monoamines within a neuron, causing excess neurotransmitters to diffuse into the synaptic space. So you can see there are more neurotransmitters are present when we are using the monoamine inhibitors. So this is the other way by which we can increase the monoamines in the synaptic cleft. So there are two types of the MAO enzymes, MAO A and MAO B. Okay. Monoamine oxidase inhibitor A metabolizes norepinephrine, serotonin and tyramine, and inhibition of this MAO A produces the antidepressant effects. And MAO B is the specific for dopamine. Inhibition of the MAO B produces anti-Parkinsonian effects. So when we read about the anti-Parkinsonian drugs, that is drugs from Parkinson's disease, we read about the MAO B, selective MAO B inhibitor. Seleginin, rasagilin, these are the selective MAO B inhibitors which will be discussed then. Seleginin, rasagilin, not discussed here. Here mainly we need MAO A inhibitor, selective MAO A inhibitor. But most commonly we are having different types of the non-selective inhibitor, that is they are blocking both the MAO A and MAO B. So these are example of the phenelgin, prenylcypromine, isocarboxazide and pargailin. These are irreversible and non-selective MAO inhibitor, also known as the classic MAO inhibitor. They cannot distinguish between two isoenzymes. Their activity cannot be restored unless new enzyme is synthesized. Therefore, when we are giving this MAO inhibitor, for 2 to 3 weeks needed after stopping of treatment to initiate a new drug, because their effect lasts for 2 to 3 weeks. Because these MAO inhibitors, if they are inhibited, the monoamines will not be metabolized until a new enzyme is synthesized, and new enzyme synthesis usually takes 2 to 3 weeks. Okay. So reversible and selective inhibitor of the MAO A inhibitor recently came, known as the moclobemide, which are antidepressant effect and short acting. That's why the adverse effects are also less. And there are selective inhibitor of the MAO B like seleginin, deprenyl, seleginin, rasagilin. You will read about the Parkinsonian chapter. Side effects, hypotension can happen. So there may be sudden hypotension, there may be antimuscarinic effects, similar anticholinergic effects. There may be CNS stimulation, there may be weight gain. All this can happen with the MAO inhibitor. And drug interactions like tricyclic antidepressant, there are very many drug as well as food interactions with MAO inhibitor, like petidine. When the petidine or morphine it is given, there may be severe hyperpyrexia, restlessness, coma, hypotension can happen. When levodopa is given, levodopa is used for the Parkinson's disease. When it is combined, there may be hypertensive crisis, what I am discussing, sudden rise of the blood pressure. Amphetamine and ephedrine, these are basically indirectly acting sympathomimetic agent. You have already read in the NS chapter, amphetamine, ephedrine. When these are used with MAO inhibitor, there may be again hypertensive crisis. There may be sudden rise of the blood pressure. When the tricyclic antidepressants are given, just now we have discussed, tricyclic antidepressant and monoamine oxidase inhibitor, both should not be given together because there may be hypertensive crisis. Again, sudden rise of the blood pressure. Again, the monoamine oxidase inhibitor and SSRI should not be given. There may be serotonin syndrome, similar to that of the hypertensive disorder. This is known as the cheese reaction, what I am talking. So tyramine is an indirectly acting sympathomimetic agent, and this is present in the cheese and cheese-like substances. So this occurs when tyramine-rich foods are taken with MAO inhibitors. So the patient is taking this MAO inhibitor, most commonly the non-selective MAO inhibitors, and the patient is taking some cheese or something, some foods like that contains the tyramine. This tyramine or tyramine-like foods are the indirectly acting sympathomimetic drugs. And already we have seen, if the indirectly acting sympathomimetics are given with these MAO inhibitors, that leads to sudden rise of the blood pressure or hypertensive crisis. And these tyramine-rich foods, what are the examples? Old cheese, concentrated yeast products, pickled or smoked fish, red beans, red wine, chicken liver and sausage. So if these patients are prescribed, they have to be told that you should stay away from these foods while you are on this drug. Okay, otherwise there may be problem. So this tyramine in food is normally degraded in the gut by the MAO-A inhibitor, and this tyramine from the ingested food is taken up, and ultimately this is converted to octapamine. This octapamine is a false neurotransmitter which causes massive release of the norepinephrine and may result in hypertensive crisis. Already they are increasing the norepinephrine. When these two are given, they give a synergistic effect, and there is sudden release of the more norepinephrine in the synaptic cleft. That leads to sudden rise of the blood pressure, and that leads to stroke or CV also. So treatment, we have to treat this cheese reaction with the prazosin or phentolamine. So this prazosin or phentolamine are the alpha blocker drug. Already you have read in the NS chapter, alpha blocker. So the treatment of the cheese reaction is the alpha blocker, prazosin or phentolamine. At least 10 milligram tyramine needs to be ingested to produce this reaction. So very small amount will not cause this. The special advantage claimed for this moclobemide is that no cheese reaction occurs with its use. So this moclobemide is the reversible inhibitor of the MAO-A that ultimately leads to very less or no cheese reaction. So cheese reaction is very important for your exam also, Viva. So this moclobemide already we have taken. This is a reversible and selective monoamine oxidase A inhibitor. Competitive enzyme inhibition basically happens. It lacks the anticholinergic, sedative, cognitive, psychomotor and cardiovascular adverse effect. That is, different adverse effects are lesser here. Particularly good option in depression in elderly patients and in those with heart disease and social phobia. So social phobia, oneke social interaction phobia thake, সেই social phobia ক্ষেত্রে elderlyদের ক্ষেত্রে বা those patients who have heart disease তার ক্ষেত্রে depression আছে, সেক্ষেত্রে আমরা moclobemide use করতে পারবো. Adverse effects are lesser. Therapeutic use, mainly MAO inhibitors, it is basically very less used nowadays. What I am talking, because of this large drug or food interactions, it can be used in some phobic disorder like social phobia, atypical depression, and in endogenous depression that is refractory to other types of the drugs. Next, coming to the SSRI, selective serotonin reuptake inhibitor. This is also very important. Fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, escitalopram. All these drugs are very commonly used. Selective serotonin. So they are currently the most widely utilized class of antidepressant drugs. They act within the brain to increase the amount of the neurotransmitter serotonin, like 5-hydroxytryptamine, in the synaptic gap by inhibiting its reuptake. So basically they are inhibiting the reuptake. That's why reuptake inhibitor, selective serotonin, because they are selectively inhibiting the reuptake of the serotonin and their effect on other neurotransmitters are less. Because this is less, that's why the side effects are also less in comparison to the tricyclic antidepressant or monoamine oxidase inhibitor. So they are described as selective because they affect only the reuptake pumps responsible for serotonin, as opposed to earlier antidepressants like tricyclic antidepressants, which can affect the other monoamines also. Okay. So you can see, have delayed onset of action extending several weeks, because again the plasticity, the change, neuroadaptive changes occur when we are giving the selective serotonin reuptake inhibitors for large number of days. So these are the receptors, reuptake pumps in the presynaptic neuron that are blocked. So when these are blocked, there may be autoreceptor desensitization. If it is given for long period of time, the receptor pumps are basically desensitized or down-regulated. That is, less number of these receptors are expressed. That's why more availability of this neurotransmitter in the synaptic cleft. The same thing, the down-regulation of the autoreceptor causes the neurons to release more 5-hydroxytryptamine. They have delayed onset of action, already we have seen. Again the same thing. So what are the advantages? Produce little or no sedation. So they have more selective action, that's why there are less adverse effects. Just remember this. So produce little or no sedation, do not interfere with cognitive or psychomotor function and produce anticholinergic side effects. So anticholinergic side effects like dry mouth, blood vision, these are less. They are devoid of adrenergic blocking action. That's why postural hypotension also less or does not happen. That's why it can be given in elderly patients, suitable for elderly patients. They have practically no seizure precipitating function. That's why epileptogenic potential is also less for these patients. Weight gain is lesser problem in comparison to the other drugs. In comparison to the MAO inhibitor, they do not cause this cheese reaction, already I have discussed. Acute toxicity also lesser, because large number of these pills, if it is taken, there is lesser chances of the acute toxicity. Fluoxetine is the first SSRI that was discovered. The half-life after a single dose is 2 days. That's why it is a very long-acting drug. The liver metabolizes into norfluoxetine and ultimately this is metabolized out. It also involves the P450-2D6 system. That's why there may be some drug interactions are there, and it is approved for use in children greater than 7 years and adolescents, and it is relatively safe in pregnancy. So fluoxetine can be given after 7 years and also in the pregnancy. Fluvoxamine is a shorter acting SSRI, T-half is lesser, 18 hours. This fluvoxamine now specifically recommended for generalized anxiety disorder, and fluvoxamine is most commonly now used in OCD, obsessive compulsive disorder. অনেকে হয়তো শুনেছিস বা বিভিন্ন মুভিতেও দেখেছিস অবসেসিভ কম্পালসিভ ডিসঅর্ডার, মনে কর কেউ একটা তালা লাগালো কিন্তু বারবার তালাটা চেক করেই যাচ্ছে যে তালাটা লাগানো হয়েছে কিনা, বাইরে বেরিয়েও, মানে অবসেশন কিছু একটা থাকছে, তার ফলে কম্পালশন, মানে অবসেশন যে ওটা হয়নি কোন একটা কাজ ওটা করা সত্ত্বেও, এবং তার দ্যাট লিডস টু কম্পালসিভ বিহেভিয়ার। দিস ইজ নোন অ্যাজ দ্য obsessive compulsive disorder. This is also common, and fluvoxamine is the treatment of the choice for this obsessive compulsive disorder. Paroxetine is another short acting SSRI which does not produce active metabolite. Higher incidence of the gastrointestinal side effects can also occur with this paroxetine. Sartarine is also very commonly used now. It is a selective serotonin reuptake inhibitor. It is very much efficacious in juvenile depression. বাচ্চাদের ক্ষেত্রে ডিপ্রেশনের ক্ষেত্রে very commonly used. It is recommended for anxiety and also post-traumatic stress disorder. So sartarine is also one of the drug of choice for PTSD, post-traumatic stress disorder. Okay, drug interactions may be there due to some cytochrome involvement. It appears to be a minor inhibitor of the dopamine receptor, and T-half is also longer. That's why usually it is given once daily doses. So sertraline can be used in the PTSD, post-traumatic stress disorder, and anxiety disorder and juvenile depression. Citalopram and its congener escitalopram, this is most commonly used in our country nowadays because of their lesser side effects and lesser interactions with other drugs and foods. T-half is 33 hours, again it is once daily used. Overdose is very unlikely. It is the preferred SSRI for mood disorder in premenstrual symptoms. Now premenstrual symptoms যেটা হয় mood disorder সেক্ষেত্রে ইউজ করা যায়। Escitalopram is the active enantiomer, that's why it needs a lesser dosing of the drug and its side effects are the lesser, and safety is more or less escitalopram used in different stages of the depression. Dapaxetine is the newer ones that is mainly used for delaying the premature ejaculation. So premature ejaculation is also treated by different types of the antidepressant drugs. One of the drug is the dapaxetine, and it acts rapidly, can be taken 1 hour before sexual intercourse. So dapaxetine can be used in premature ejaculation. Side effects is not important. Adverse effect of all the SSRI, most commonly the gastrointestinal symptoms. Remember, if the patient is taking the SSRI and also the patient is taking some other drugs, that leads to gastrointestinal intolerance. Usually different guidelines say that we should give some prazoles like pantoprazole or omeprazole. Pantoprazole is usually preferred because there may also risks of the gastric bleeding that can happen. So gastrointestinal symptoms can happen. Changes in appetite, weight loss or gain, sleep disturbance can happen with fluvoxamine, anxiety, tremor, and in the flip side, some of these drugs also leads to some sexual dysfunction also. So some of these drugs can be used for the treatment Again, some of these drugs, if it is used for some other purposes, that leads to problem in the sexual dysfunction. And discontinuation syndrome, that lead to headache, malaise, flu-like symptom, agitation, etc. Drug interactions are lesser, but it can happen most commonly again with the MAO inhibitors. With the MAO inhibitors, it is known as the serotonin syndrome. The syndrome is more or less similar to the cheese reaction. There may be tremor, hyperthermia, cardiovascular collapse and death. So again, this MAO inhibitor should not be given together with the SSRI. This should not be given with the tricyclic antidepressants also, because there may be problem. Now coming to the some other atypical antidepressant drug like norepinephrine selective reuptake inhibitor. Just remember the name reboxetine and tamoxifen. Advantage is they lack the antagonistic activity in different other receptors. That's why the side effect is less. Details is not required. Just remember the name reboxetine and tamoxifen. SNRI. This is important. SNRI is the serotonin and noradrenaline reuptake inhibitor. Now in our country we have venlafaxine and duloxetine. Venlafaxine and also is there, but levomilnacipran is not available. Just remember duloxetine and venlafaxine falls under the group of serotonin and noradrenaline reuptake inhibitor. The previous one was the SSRI. This is known as the SNRI. Okay. They inhibit the reuptake of the both serotonin and norepinephrine, effective in treating depression, where the SSRI will not act. Sometimes effective in relieving pain. Now this duloxetine is the drug of choice for the diabetic neuropathy, for example. So they are used for diabetic peripheral neuropathy, post-herpetic neuralgia. So herpes zoster is a disease that leads to severe neuropathic pain, for which we can use this drug. Fibromyalgia is an unexplained pain symptoms or chronic fatigue symptoms. So there may be pain in different joints, unexplained. There may be no pathology. This is known as the fibromyalgia and low back pain. So basically remember, these SNRIs are the first line of drugs due to different types of the neuropathic pain. Most commonly diabetic neuropathic pain, post-herpetic neuralgia, fibromyalgia, low back pain, for which we have to use the venlafaxine, duloxetine. Apart from their antidepressant action, they have little activity on the alpha-adrenergic, muscarinic and histaminic receptor. That's why the side effects are the less, and they also precipitate discontinuation symptoms in some of the cases. So site of action for the different antidepressants already we have discussed, you already know. So there may be, this is the serotonin transporter and this is the norepinephrine transporter. We are blocking these transporters or we are blocking the metabolism. So these are the different drugs. For example, MAO inhibitors, already we have seen. MAO inhibitors are blocking the monoamine oxidase that ultimately inhibits the metabolism. There may be tricyclic antidepressant and SNRIs that blocks this norepinephrine transporter and serotonin transporter. SSRIs selectively block this serotonin transporter. Tricyclic antidepressant blocks different other transporters also. So these are the different drugs that mainly acts to increase the synaptic cleft availability of the different monoamines. So uptake inhibition also varies for the different drugs. For example, you can see fluoxetine is the selective serotonin reuptake inhibitor. They have no uptake inhibition on the norepinephrine, but the maximum uptake inhibition on the serotonin. Similarly, the SNRI, already we have discussed about the duloxetine and venlafaxine. Somewhat they are blocking this norepinephrine and also blocking the serotonin, very large. And tricyclic antidepressant is a non-specific blockers of the different receptors. So all these, and within the group also, one drug varies from the other according to their selectivity and their potency of action on different receptors. Atypical antidepressants, already we have discussed. Another important drug is the bupropion. Bupropion is an antidepressant of the aminoketone group. They has excitant rather than sedative property. So when bupropion is given, they are giving some excitant effect in comparison to the other ones. And bupropion is basically useful. What are the use of the bupropion? Decreasing the cravings and attenuating the withdrawal symptoms of the nicotine in patients trying to quit smoking. So smoking cessation এর ক্ষেত্রে different drugs use করা হয়, যেমন nicotine chewing gum আছে, অন্য আরো কিছু drug আছে. The most important is the bupropion. So bupropion is the antidepressant drug that is used for the smoking cessation that decrease the craving of the smoking. Side effects, there may be dry mouth, sweating, nervousness, etc. They are also metabolized by the cytochrome enzymes and they are contraindicated in bipolar disorder and seizure. So bupropion is a drug used for the smoking cessation. Remember, very important. Trazodone and the nefazodone is serotonin 2A antagonist and reuptake inhibitor. So they are blocking the receptor also, serotonin 2A receptor and also reuptake inhibitor, and antagonism also reduces the risk of anxiety, sedation and sexual dysfunction. Okay, and they are powerful 5-HT2A antagonists. Previously we are blocking only the reuptake pumps or blocking the metabolism. They are also blocking the receptors. Mainly these are trazodone is commonly used off-label for the management of the insomnia. So sleeplessness we can use. They are very much sedating, but this trazodone is lesser used now because of the two adverse effects. One is the priapism, has been associated with the priapism. Priapism is the sustained contraction of the penis. That leads to sustained and painful contraction of the penis that may happen with trazodone. That is known as the priapism. And hepatotoxicity is another important side effects of the trazodone. This is also important. These two adverse effects. And both of these agents may lead to orthostasis and dizziness also. That's why it is used lesser in some of the cases. But they are better suited for the elderly, or already you have seen. They can be used in some of the cases of the elderly. Mirtazapine is used more commonly in comparison to the nefazodone. They are presynaptic alpha-2 receptors antagonist. So presynaptic je alpha-2 receptor take tar antagonism korche, in addition to the antagonism at the 5-HT2 receptor. That's why they are known as the noradrenergic and specific serotonergic antidepressant. And this mirtazapine is very much sedating because of its potent antihistaminic effect. That's why those depression patients who have very high level of the insomnia, usually we are using the mirtazapine. Commonly used kora hoy mirtazapine. They does not cause any antimuscarinic side effects. The interaction with the tricyclic antidepressant or the sexual function is also very less. Increased appetite and weight gain can frequently occur. Otherwise, more or less similar. Mianserin blocks the presynaptic alpha-2 receptors, but just remember the name because it is lesser used now because of the blood dysphagia and liver dysfunction. It is not used, lesser used now, but this mirtazapine is more commonly used. Remember, when there is insomnia, depression, if it is associated with insomnia, we have to use the mirtazapine. Tianeptine is used mainly in the angiodepressive disorder. Just remember the name, details is not required. Vilazodone is the newer ones, used similar to that of the SSRI. Other SSRI jekhane use kora hoy. Vortioxetine, just remember the name, another newer ones because the side effects are the lesser and used in the similar types of the cases. So these are the therapeutic uses of the antidepressants, what we are discussing. So endogenous or major depression, this is the first indication of the different types of the antidepressants. Depression, we have to start with the antidepressant drugs, already we are talking, and we have to wait for the minimum 2 weeks to 2 months, and then we have to add another antidepressants according to their side effect profiles or to see whether any interactions between these two is present or not. Or we can change the antidepressant drug if it is not occurring. Then the panic attack on acute episode of the anxiety, different types of the panic attack. There may be some social phobia or other types of the panic attack, acute episode of the anxiety, generalized anxiety disorder. These antidepressant drugs can be used in addition to benzodiazepines. Obsessive compulsive disorder, already we have discussed. Attention deficit hyperactivity disorder, this is mainly seen in case of the children and adolescents. Attention deficit hyperactivity disorder, again this SSRI is given. Chronic neuropathic pains or unexplained body pains. Now the first line of the drugs, this neuropathic pain is different types of the SNRI and then the SSRI. Usually the duloxetine or desvenlafaxine or venlafaxine is used. Then other SSRI like escitalopram or fluoxetine can be used. Fibromyalgia is similar to the chronic unexplained pain symptoms. This is known as the fibromyalgia where the antidepressant drugs are also used. Premature ejaculation, already we have seen different antidepressant drugs can be used premature ejaculation. Eating disorder, another thing, very important thing. So there are mainly not only bulimia nervosa, there are two types of the eating disorder is there. One is anorexia nervosa, another is the bulimia nervosa. Anorexia nervosa means the patient will not eat anything because of their false assumption that he or she is very fat, even if his or her BMI is less than approximately 15 or 16. So ultimately this anorexia nervosa, it is difficult to treat, and ultimately the mortality is also approximately 10%. You can search in the internet and you will see that very many famous models have died due to the anorexia nervosa in the Western countries basically. And another is the bulimia nervosa. The patient eats bulimia nervosa, binge eating. They are doing some binge eating, and then out of the guilt, they are just vomited out. Okay, so this is known as the bulimia nervosa, anorexia nervosa, bulimia nervosa. These are also treated by the different types of the SSRI. Most commonly the fluoxetine, sertraline, escitalopram and citalopram. Usually these are used, and also counseling is required. Premenstrual dysphoric disorder. This is also common. Around the menstruation, there may be some dysphoria, different types of the, we have to use the different types of the antidepressant drugs. Enuresis. Enuresis means nocturnal micturition. Mostly it is seen in case of the children, and imipramine is still now used very commonly and very successfully for treatment of the nocturnal enuresis. Okay. So nocturnal enuresis, imipramine, which is a tricyclic antidepressant, is used. Migraine. Migraine, you have already read about the migraine. So probably you have read na migraine. Autocoids পড়েছিস. So there may be acute migraine, chronic migraine. কিছু chronic migraine যাদের ক্ষেত্রে migraine অ্যাটাকটা বারবার হয়, if we are continuing with the antidepressant drugs, there are some antidepressant drugs that will leads to decreased frequency of the migraine attacks. So migraine এর ক্ষেত্রে ইউজ করা যেতে পারে। pruritus, কিছু ক্ষেত্রে unexplained pruritus থাকে, বিভিন্ন জায়গায় itching হচ্ছে, in those cases also this is due to the some neurotrophic factors, that also we can use the antidepressant drug. So this is very important. What are the uses of the antidepressant drugs? So these are the different uses. So thank you. So this is all about the antidepressant drugs. Any question?